It is.
Well, we'd like to welcome everyone to this week's Journal Club. My name is Stephanie Wyrock, and I've been leading these Journal Clubs every week since basically the pandemic started. I'm the Vice President of the APTA Connecticut chapter, and today we're joined by Anthony Cucco, who will be presenting his article that he chose for the week, Pain-Free versus Pain Threshold Rehabilitation Following Acute Hamstring Strain Injury, a Randomized Controlled Trial. So I'll let Tony introduce himself, and he can get started. Just some quick reminders. If you do have any questions or comments, please type them in the chat box. We will be fielding them throughout the presentation. We'll likely come back to them at the end. So if you do have any questions, try to keep them for the end, and then we'll open it up for discussion. So Tony, go ahead.
Hi, everyone. Welcome. I hope I can do this some justice. This was the article I chose, basically dealing with pain-free, as you can see, versus pain threshold rehab. I think we all, as clinicians in the outpatient realm, realize that there are a lot of times we are working with patients and pushing them through some discomfort that they may not be interested in experiencing. So if you'll bear with me, there's a large part of this presentation that I thought I was going to end up presenting, but I'm going to ditch it, and I'm just going to try to go through some of these slides really quickly, so please bear with me. This is not the actual, we're going to start out with some background information I think that's just relevant to what we're looking at tonight, so bear with me, I'll go through it real quickly. So the first thing is, I think it's important to understand hamstring injuries are pretty common. There's a very high incidence, technically, there are more strains than any other strains that you see in athletics. And it's important to understand there's a long recovery time with hamstring strains. I'm sure most of you are aware of this. And there's a real high index or a suspicion of re-injury within the first couple of weeks after someone returns to play, which is basically what we're dealing with here. And you can see a couple of pieces of information there. Previous hamstring injury increases your risks either 2 to 6-fold for another hamstring injury. So a number one risk factor, and that'll be relevant for this study, as you'll see. It's important, I think, to just at least remember that there are different types of hamstring injury. You've got the acute type, which is the most prevalent, which was what this study deals with to some degree, although we're going to talk about that a little bit. We all are aware of ischial apophyseal avulsions that you see mainly with adolescents. Then you get a complete or partial proximal hamstring tendon avulsion, and you also may be dealing with a patient who's got a proximal hamstring tendinopathy. And then, of course, we have incidences of referred thigh pain. When someone comes into the clinic, certainly, I think we're all thinking of those issues. I'm going to pass on a lot of this. Let's see. Basically, you're looking at two types of acute hamstring strains, which we're dealing with in this study. The type 1, which is a high speed, it's typically a biceps femoris is usually involved, and it's typically a proximal injury. For the type 2, this is an excessive lengthening kind of thing you might see in dance or high kicking, where the proximal free tendon, it's typically semimembranosus, not biceps femoris. And these are typically longer to recover. And even though they are technically usually a slower mechanism of injury for the type 2. Different types of muscle strains, we're all aware of those, grades 1, 2, and 3. I think this study we're probably going to be dealing with, although they don't talk about it in this study, pretty much, I believe, grade 2 for the most part, I believe, grade 1, 2. Not that simple to tell. Quick anatomy look, we all are aware of the anatomy. Again, biceps femoris is the more often affected. Risk factors for an acute strain, previous strain, typically when the 1 to 2 weeks, first 2 weeks after return to play. You can see some of those other risk factors, older age, persistent weakness, and extensibility, which is also an important factor. Risk factors, we'll come back to that. I think I want to point out this MRI, that there are length and cross-sectional areas are directionally proportional to recovery, but they're really not that effective for predicting re-injury. And you'll see in this study, they did not utilize MRI. They did utilize ultrasound, and there's really no correlation between that in the study I looked at between the length of the injury area and the severity and the recovery. But they did in fact use that. Typically, people who have an acute injury will have pain for, with ADLs for 3 days. They get an audible pop or an injury. Basically, you're looking at roughly a 15-degree difference between passive knee extension versus the uninvolved limb. Time to walk test, they don't use that. We'll revisit that potentially later on. I'm going to move on and get right to the study. So this study is basically, the premise of this study is as follows. We're looking at the eccentric loading and long length exercises utilized to reduce hamstring injury risk. And when these are emphasized during rehab, typically we do have better results as a general rule. And delaying utilization of these exercises has been shown to delay recovery. If you wait as long as 9 days as opposed to 2 days, you're going to prolong the time to return to play. Oftentimes, we're avoiding pain after an acute muscle injury, and that's pretty much your conventional guideline. I think we'd all agree with that for an acute muscle injury, as opposed to, I don't know, a chronic rotator cuff tendinopathy, those sorts of things. But there's really not a lot of research to support why we really shouldn't be exercising people or working people through some pain during acute muscle injury. Basically what they're saying is that we use chronic and post-rehab pain on a regular basis to recovery people, and it probably improves outcomes to some extent. I think we could all answer to that. So the objective of this particular study was to compare the number of days that it took to get a patient back to return to play after an acute hamstring injury. The difference being you're either going to go into a pain avoidance or a pain-free protocol versus a pain threshold protocol. And secondarily, they wanted to compare the pain-free and the pain threshold groups in terms of strength of isometric flexors, the biceps femoris long head fascicle length, and the fear of movement, as well as at 6-month follow-up, and see if there was any re-injury. So the hypothesis they were dealing with is that the pain threshold rehab would accelerate the time that they would be able to achieve return to play as opposed to the pain-free rehab group. If you take a quick look, for those of you, let's see. So this was a single-center, double-blind, randomized control trial. They ran for about 1.5 years. They recruited males and females ages 18 to 40. And the people who were coming in being screened were suspected that they had a hamstring injury within 7 days of some sort of acute onset posterior thigh pain. They excluded people with hamstring tendinopathy or referred low back pain, or if there was any suspicion of rupture or avulsion, any reason to refer this patient to a physician for imaging or evaluation. There was no MRI confirmation of injury. I think that's important to note. And basically the rationale for this is that research has shown that between leg deficits in strength, range of motion, and pain correlate well with rehab progression, and they do end up explaining more of the variance that we see in return to play clearance time, as opposed to MRI findings. They took the sample and they basically stratified it. I'm glad they did, based on the history, the background I was giving you earlier, is that they've got males and females with previous versus first-time hamstring injuries in the group. Again, everyone in the study had an acute hamstring injury, but there are those who were injured previously, and we'll talk about that some more. So in terms of breaking up the sample, you've got your pain-free group and your pain threshold group. Pain-free were only performing or progressing exercises with complete absence of pain on the numeric rating scale 0 to 10. Those in the pain threshold group were basically able to perform any exercise or progress any exercise if the pain rating was 4 or less on the numeric rating scale. So that's the basis of this whole study in terms of what they're trying to get at. Everyone filled out a Tampa scale of kinesiophobia, which is basically about fear of movement. They did do ultrasound imaging to assess the biceps femoris long head architecture. They palpated the injury location and the peak pain that they achieved in that prone position. They also included the distance from the ischial tuberosity and the length of the palpable pain segment. All that was recorded. Hamstring range of motion was evaluated by passive straight leg raise and an active knee extension test. And they're basically looking at how much excursion did you get before you got localized pain or a maximal strength. They did both of those tests, 3 trials each, and they took the highest recorded range of motion for each. Isometric knee flexor strength was done in supine at 0 degrees extension, 0 degree hip flexion, 0 degree knee extension, knee flexion, and in 90 hip flexion, hip knee flexion. They took the highest force output across the 3 reps. Now, they used an apparatus that had been validated in a previous study, so I want to share with you what that looks like. Bear with me here. This is the apparatus that they used to evaluate hip flexion. I can't. Let's see. That is, this study was looking at the pictures you're seeing here was done with the bridging, but that is the apparatus they used, but there was no lifting of the gluteals off the table, so that I'm aware of. Although I have to double check that. But that is the apparatus they used to test knee flexor strength at both the 90-90 position and the 0-0 position. So that was one of their main outcomes. So the protocol was twice a week, and all of the exercise was supervised in terms of hamstring strengthening, as well as a progressive running program, which I'll share with you in a little bit. There weren't any pain relieving modalities utilized in the clinic, but they were not controlled at home. And I don't know if they didn't clearly state whether or not they were allowing these individuals to ice or use medication. I don't know if that was well controlled. It was a little unclear, but there certainly were no pain modalities used in the clinic at all, the twice a week. There was no rehab performed outside the clinic. However, they did allow these patients to run with their progressive running program. So if you achieved a certain level of running, and we'll see that program in a little bit, you were allowed to keep running below that threshold you had achieved in the progressive running program when you weren't in the clinic. But you weren't doing any of these eccentric or lengthening exercises on your own. And they were also allowed to return to their sport of choice that they were playing or trying to get back to and participate with their teams, but they were just given instructions to gradually go back and, stay within their pain threshold. Let me show you now the exercises that were being performed for the study. All right, here's the video of the double leg. I'll let it speak for itself. Hamstring bridge. Again, this was not the testing method. This was the exercise method. -45-degree hip extension. There's the apparatus they tested the knee flexors with. So those are the bilateral exercises used. All right. And the unilateral exercises were similar. So same exercises performed bilaterally and unilaterally, except for the Nordic hamstring exercise, which was performed. I'll see if I can pull up that video as well, but we'll revisit. There's a 9-stage progressing running protocol, and basically it's 50 meters where they begin walking, jogging, running, and then sprinting. And that's basically the progression you're working with. A 50-meter started with a walk, then a walk jog. And they would have 3 phases: acceleration, hold whatever speed that was, and then a deceleration phase. And if I try to, let me see if I can pull that up as well. These are your unilateral exercises. As you can see, all lengthening movements. Again, that's also the testing apparatus. I think I might as well say it now as I'm thinking about it. I mean, we all know that a lot of these are not all going to be possible to do in the clinic, depending on where you are. But I think it's important to realize that these are important ways to address the hamstrings. If you have access, or you can get access to something similar in your own clinic. So let's get back. So the running protocol. I got to see if I can pull a picture of that up. It's basically what you're looking at on this is a 20 meters of acceleration followed by a 10-meter hold phase, then a deceleration phase of 20 degrees. So think of it as, if you want to look at an issue at a time when you might be getting close to return to play, you might be running 10 meters, and then you will sprint, get up to a sprint and sprint a certain distance, and then you will have a certain distance to decelerate. And that changes as this progresses in terms of what percentage of the running is accelerated versus hold versus deceleration. So the patients were contacted 1 time a month for 6 months after re-injury, to look for re-injury after they returned to play. And then they were brought back 2 months after return to play clearance, as long as they weren't re-injured, for reassessment, and all the same tests were conducted. So overall, the results were as follows. They ended up with an all-male sample. I know hamstring injuries, acute hamstring injuries, are more common among males than females, but there were no females included in the study. There were no adverse effects or injuries during the rehab. And I think the most important thing to take out of this is really that these two protocols really did not have any significant difference in return to play. The pain-free group was able to return to play within 15 days, and the pain threshold group an average of 17 days to get back to play. There was some of the secondary outcomes. The biceps femoris long head fascicle length improved for all of them from initial assessment to return to play, although the fascicle length from the initial assessment to the 2-month follow-up after they returned to play was better in the pain threshold group. The pain threshold group improved the knee flexor strength equally to the other, the pain-free group. However, at 90-90, there was a 15% greater improvement versus the other leg for the pain threshold group. Importantly, 2 patients in the pain-free group re-injured at 50 and 67 days after they were returned to play. And they had originally been cleared at 13 and 26 days after their original injury. And then 2 patients in the pain threshold group also were re-injured, but they was much sooner at 8 and 17 days after they were cleared, which I think is an important issue. They don't really talk about it too much, but we'll get to that. And their return to play clearance was at 6 and 11 days. Interesting, they were back pretty quickly, but they both ended up getting re-injured relatively quickly. So, I mean, return to play clearance after acute hamstring injury is not accelerated by the pain threshold protocol. I think that's clear. The pain threshold protocol resulted in greater recovery of isometric knee strength at 90-90, which is typically your most powerful position for both the return to play and the 2-month post-op. So that's really one of the major differences between the 2 protocols. And I think the takeaway from this, and these are the authors' takeaways, and I do agree with them. The early initiation of eccentric loading and lengthening is safe and effective. I know personally, I oftentimes will resist going to these types of exercises when there's a lot of pain. But I really, since reading this article, I actually have changed a couple of my patients, and I'm a little more likely to utilize these exercises if there's a little pain, as long as it is manageable. It's important to note that other authors and clinicians were avoiding these types of exercises in studies and in terms of waiting until their full range of motion was there, they were pain-free, and they had at least, knee flexor strength that was within at least 10% of the uninjured leg. And they would use that as a basis before they would start doing eccentric loading and long length exercise, which to me seems very practical that you would do that. I mean, I would always probably think that way as well. The 11% re-injury rate is pretty much consistent with other re-injury rates that are observed in the literature. And I think the findings suggest that, there's a possible relationship between, return to play clearance and these elevated, these accelerated sort of programs, because you did have re-injury rates within a few days on both. I think some of my key observations of the study would be that 73% of the pain-free group and 67% of the pain threshold group had previous hamstring injuries. And I think if I went through that whole presentation, a lot of those slides that I passed up on earlier, the previous injury is very important, and there's a lot of factors that go into that. And I think that's one part of this study that they really did not address or speculate much on that portion of this. On the other hand, I could say, well, the fact is that they had a lot of people with a history of a previous strain, and they did pretty well considering. So you probably could look at it either way, but they didn't really evaluate that. And I thought to myself, pain threshold exercises, I mean, we do it all the time with tendinopathies, certainly at the patellar tendon, the Achilles tendon. We do it for osteoarthritis, certain joints, and we certainly do work through pain for total knees, total hips. But I don't know if that's a really good comparison for these acute musculoskeletal injuries. But maybe it is different for chronic and previous injury, because the bullet point above is that most of these patients indeed did have a previous injury, and they did respond well to this program. There weren't any controls of the volitional running and team practice settings. I don't really know what effect that had. They didn't speculate on what impact that might have had on the results. It is important to note that 3/4 of these participants were not only male, I mean, they were all male, but 3/4 of them were Australian football players. So there is some sports specific, conclusions that you really should make from this. Certainly sex specific, gender specific, and sports specific. The intention to treat, I'm hoping somebody in the audience knows more about it than I. I'm familiar with the concept. I understand what it is, but their explanation of their intention to treat was unclear to me, and I'm hoping someone in the group can shed some light on that for me. I found it confusing. I think it's important to note there were no manual therapies or modalities performed here. And most of these patients had a previous injury without an MRI assessment as well. So I wonder how many of these people had tendinopathy, would any of, certainly manual modalities, manual therapy been indicated here? I'd be interested in what anybody in the group has to offer there. I would wonder, I don't personally do any dry needling. I'd wonder whether that was something that would have been helpful here. You just have to keep this in the context of what it is they did here. And I think based on, if this was a sample of, 21 or 22 initial injury acute hamstrings, maybe I would have a little bit of a different take on that. But the fact that there's some level of chronicity with this, and for me, a previous hamstring strain is chronicity on some level moving forward. So I know I went through that kind of quick, but we have plenty of time to discuss what we saw here. Steph?
Yeah, thanks, Anthony, for the wonderful presentation. We'll open it up to the audience as far as questions or comments. First of all, does anybody, how often do you guys treat acute hamstring strains or even chronic hamstring strains? And feel free to unmute yourselves.
Yeah, thanks, Anthony and Stephanie. My question is more about how they chose the methodology in this research. It's primarily like when they started treating those acute hamstring injuries, like even before they entered the second stage of healing, and there is 11% re-injury rate in the group. So that's why my thoughts are like, maybe this method of including the exercises, like pain threshold exercises for the hamstring rehabilitation, maybe more like that concept might be more appropriate with the repetitive hamstring injury patients rather than the first time acute hamstring injury cases. So that's what my thoughts are like. Maybe that's if they're doing the pain threshold strength training exercises for the hamstrings that are involved in the first time, it might be a little too much for them to recover 100%. So that's what my thoughts are on this research.
Well, I agree with you in that the one thing I would say, though, is that both the pain, in terms of the pain threshold, even the pain-free people, there was the same re-injury rate among the pain-free and the pain threshold. So on that note, they're not much different. I think I'll look at it this way. I think the pain threshold portion of this comes through quite well. But the question is, should you be putting anyone through this type of aggressive, relatively aggressive rehab program to avoid any re-injury, going back? And that's, of course, the aim. One of the problems with this methodology or the sample size is that it would be nice if they had enough sample size to do a subgroup analysis of the first-time acute hamstring injury versus those who had a previous injury. And there's just not enough power in this sample to look at that. But I think that is a really key component. And then we could address what you are talking about. Should we really be looking twice at this for those who've been injured before versus first time? So I agree. And it is early in the process. I mean, these people are still in, they're not even in a proliferation phase, and they're being sent back to play. I will add that there are plenty of articles out there. There's a few that I came across that do show that MRIs in among patients or athletes who've returned to sport still have significant edema and scarring that show up on an follow-up MRI even though they've returned to play. And some of the speculation is that maybe it doesn't matter, but maybe it does.
I mean, traditionally, like, we would like to match the stage of the condition, like the stage of the soft tissue injury. In this case, it is the hamstring injury. We would like to match the stage of the healing process to the stage of the condition, and the exercises that we give the management in each phase. So that's
I
how.
agree.
Yeah.
Yeah.
But
I think that would be a better. I mean, I think this study could be expanded greatly if as long as they can get enough sample size, and then you can do a lot of these analysis that you're bringing up, which those are important considerations in this, because clearly the re-injury rate is a problem with hamstring injury. There's a lot of research out there, but I don't know if anybody's really done a large enough study to really look at this. There's some excellent review articles. I would direct your attention to review article by Erickson and Sherry, which was sort of a good place for me to start. It became a real important article for me to start looking over a lot of this. There's a lot of issues that could be elucidated out of this.
Yeah, I mean, I really like the central idea of the researchers, where they are not waiting for the full stage of healing to take place to start with the exercises and return to play. And it's like we don't even have to follow all the time. Like, we don't even treat the patients as same for every condition or any stage of the disease. But again, we go with the clinical reasoning, and I think if they're successful in at least giving 80 to 90% of the patients return to play in a short period of time, I think the exercise approaches, like in rehabilitating the acute hamstring injury, I think it's a good approach. It's a very novel approach.
Yeah, I mean, I think look, this study, if you really want to just take this study, and we have to do it with a lot of research, and you just look at the very narrow focus of this, and you just stay there. I have a tendency, I'm probably like you, I forgot your name, to get caught up in a lot of the sort of expand the area of focus. In this case, again, their look was, does it matter if there's pain and we work through it? And the answer is no, it doesn't seem to matter. So I think you can sort of say that, at least, whether or not the programs in and of itself are too aggressive still, and not as good at eliminating re-injury or getting even less re-injury rates is certainly the question. And then this issue of, shouldn't we be paying attention to what level or what phase of recovery they're in from a histological standpoint in terms of the tissue itself.
Yeah, I mean, in my background of the McKenzie method of mechanical diagnosis and therapy, we usually start 3 to 4 weeks after the acute injury, applying the specific principles of contractile dysfunction.
Right.
But in the acute phase, we just still follow the medical model, like trying to rest, ice, compression, elevation, and all those the traditional biomedical model, treating with if any necessary modalities if needed.
Yeah.
But going with the specific MDT method of treating the muscle dysfunction of the hamstring, that would typically is more applicable. Like, the technique would be more applicable around the phase of the end of 3rd week and beginning of the 4th week onwards.
Right. Right.
And again, in the management process of the contractile dysfunction of the hamstring injury, we actually try to provoke the pain, and the after effect after finishing the exercises should be no worse. So we do follow the same concept of pain provocation, but the pain should not be worse after finishing the movement or after completing the exercise.
Right. I agree. Yes, definitely. I mean, I think that's where these authors are coming from. that it's something that we may be avoiding with skeletal muscle that maybe we really shouldn't be. But that's it's an enormous area of study, because you could adapt, you could sort of start talking about this with other injuries as well. But at least in this case, the return to play factor in this can't be people want to get back, and athletes are in a hurry to get back, and the therapists and the physicians want to get those people back. That's what they want. And getting them back faster is what their job is. But there are risks inherent in that, of course.
Thanks for that comment, Naga. That was great. Do most of you guys see patients in the clinic that have hamstring strains? And if so, how do you typically rehab them? How close is your rehab protocol, or what you typically do, to this protocol presented in this article?
Well, I can tell you, in the last year, I've probably treated about half a dozen of these, but they're not your typical acute hamstring. See, I've treated actually two marathon runners who've had basically a proximal tendinopathy. So I do use some of these exercises, but it's a little bit of a different tack, because they're not going to stop running. And in terms of tissue quality, it's a different injury, I even treated an 81-year-old woman with a proximal hamstring strain, and she didn't have an MRI, but I think I was pretty sure that she had some sort of rupturing of that hamstring tendon. She had just bent over to do something and done it. Did I try to introduce some of these exercises? Yes, at some point, but obviously in the context of her age and her ability to perform I was at least doing some lengthening. And I recently had a soccer player who's about 42 years old with an acute strain, and I did some of these. But again, I haven't utilized this entire program because some of these exercises I'm just not comfortable with the risk that they may re-injure. They're not getting back to play. I don't feel the same pressure. I haven't treated. Look at it this way. I haven't treated anybody between the ages of, I would say, 18 and 30 with an acute hamstring strain in a couple of years. A lot of them have been middle-aged.
Yeah, that's what I find too. In my clinic, I think most of the acute hamstring strains that I treat are middle-aged as well. And I've probably only had maybe one or two patients who've been able to eventually do a Nordic curl.
Yeah, I know, right?
No, so it's like, I mean, kind of what one of some of the deficits I think of this study is, obviously it's the generalizability is an issue. It's a young population and it's all males.
Yep.
And they're all athletes, which, hamstring strains are very common in athletes, obviously. But, it'd be interesting to see how a protocol like this could be implemented in a maybe a more recreationally based population, or even potentially looking at the correlation between studies that have looked at this specific injury in an older population.
Yeah, I think it's almost, I mean, you know how it is. You should do the same thing. I'll take any number of these exercises and try to make hybrids of them so that they're applicable to someone who's not an athlete,
And I think the other thing I liked about this study too was that, in the end, whether you do a pain-free protocol or a non-pain-free protocol, the outcomes are similar. I mean, there was a little bit of better strength gains, long-term strength gains in the group where they, where they were able to, they didn't limit pain too much in the group, but overall, I think that it was good that they reported on the results of the study as being basically that the results were similar at the time points.
Yeah. Yeah, when I look at this kind of thing, after I read the whole thing and I went through it, I saw the re-injuries and et cetera. It sort of harkens me back to what I say to my patients, and I'm sure you get the same thing. People to come in and say, well, so and so athlete had this injury, no matter what it is, and they were back in 4 weeks. Why is this taking so long? And I'll say to them, yeah, but you don't know what happens to this athlete at the end of the season. You don't know how much pain this patient is in, that athlete is in, and what they're putting up with when they go back. You're assuming that they waltz onto the field or the court and they are completely pain-free and they have everything's resolved and everything's hunky-dory and they go and they play. That's not necessarily the case, and a lot of them will re-injure or have to rehab these things again after the season, which is, especially with a hamstring, yeah, they'll get through the end of the season perhaps, playing at maybe less full capacity, and then at the end of the season, now they're looking at a tendinopathy as opposed to an acute hamstring strain.
Yeah, in the past, I have used the Pilates reformer table for rehabbing the hamstring injury or quadriceps injuries, and I mean, it's very. I mean,
Similar.
yeah, the principles are like, or even the setup is like, it's not exactly the same, but it's very similar to what the videos that you have shown. Like, it's like a suspension straps, the TRX straps that you have
Yeah,
demonstrated.
that's an excellent point. If you've got I know a friend of mine's got a couple of reformers in his clinic, and next time I talk to him, I'll ask him, because I'm sure there's a lot you can do with the reformer. That's what you have in your clinic? You have
Not,
the full reformer?
yeah, I had the ones when I was working in the Danbury Hospital outpatient rehab in Main Street Rehab.
Oh, they had one there?
Yeah, and then we had in my previous job when I was at the Yale Spine Center, we had one in that one too.
Yeah, they're great. I mean, they're great. All this long, a lot of this, a lot of trunk. I mean, I didn't go through it. The presentation I started throwing together around this article. Also, there's been significant data out there, study about lumbopelvic control and its contribution to rehabbing these injuries. And there's good results out there with that as well. There's a couple of studies that have compared the eccentric portion and the lumbopelvic stabilization sort of exercises as well, that they're still important. There's a study out there that says, it may be important. You look at runners and they notice that the re-injury rates were higher in people running the 4x400 meter relay as opposed to the 4x100 meter relay. And the difference, of course, is that there's a big turn in the 400 relay and there isn't in the 100. So that was an interesting thing, because they said they were inferring that maybe that had something to do with the lumbopelvic control and fatigue in terms of hamstring strain. But yeah, there's a lot of stuff out there. The good thing that this study did, at least they focused. Again, it is just athletes. It is just Australian football players. But it is a standardized approach. I think the only real weakness to this study was that there are no females. That's number one. And number two, it's very sports specific. And three, there were a lot of people. This was really almost a study of people who've had previous hamstring injury. It's a little bit misguided to talk about this as an acute hamstring injury when 70% of the people in the study almost 70% of them have a previous hamstring injury. It's almost like you're treating people. That's a different population, different sample, I should say.
What do you typically do, Tony, for your running protocol when you have people with hamstring injuries who need to get back to running?
Well, if they're mid to long term, long distance runners. Like I said, I had one marathon runner. The other one was running mostly 10Ks. Both were females in this case, so it's not comparative to this. But typically, I'll start with a lot of gluteal work and a lot of lumbopelvic work to start, because a lot of times a lot of times in these cases, I'm getting people in middle age who have a strong potential for potentially a little bit of lumbar involvement in addition to their chronic tendinopathy. And of the two patients I'm thinking of, one of them, it just wasn't clearly just chronic hamstring tendinopathy. There was a back component to it. So she was dealing with both, and she didn't like to hear it. And the doctor told her the same thing, and it was really difficult for her because she didn't want to stop. So I was trying to actually really go slow and have her stop running, but I couldn't get her to stop running. So I did do some of this lengthening, but it was I started with lumbopelvic, went from there, and then I would slowly start to go into these bridging exercises, etc.
Yeah, I thought it was interesting that they chose the running protocol that they chose, especially because these are Australian football players, so they're soccer players. They're
Right.
running continually.
Right.
And they're more endurance athletes than they are sprinters. So
Right.
the protocol that they ended up choosing was more of a sprinting protocol versus a distance protocol, which I thought was kind of an interesting choice. Do you think?
Well, I think maybe they're reacting to the sort of glycolytic, the sort of glycolytic effect that you get playing soccer, where you're going from a jog to full-on sprint, and trying to replicate that. I would think,
Does anybody have any other questions for Tony? Or any other comments that they'd like to add?
I just wanted to request the second research article that was pulled from JOSPT. I would like the reference. I would like to read that as well. So if they can attach the reference articles.
The second article, you mean the one that talked about the apparatus that they used?
Yes. Mm-hmm.
That was, I could actually tell you off the top of my head what that is. That's, let me see.
Is it from January of 2020?
No, it is not. That's a little older. That article was actually JOSPT 2018.
2018.
48,
okay.
volume 48. I believe it's the second volume 48, number 2, I believe. And the lead author is Hickey.
Hickey, okay. Thank you so much.
Hickey, JOSPT 2018, volume 48. And that was the article to test the reliability of that, among other things, of that apparatus.
Thank you.
Which is actually, I was about to say that one of the problems with this study is some of the equipment and the testing is something you can't do. But then again, you could actually hybrid test using the reformer or some TRX straps, at least for your own sort of customized testing and training,
Well, thank you, Tony, for providing us with some insight on the article. It was
You're
a
welcome.
great presentation.
Thanks for having me.
We don't have a scheduled journal club for next week, but in 2 weeks, Naga will be presenting. So hopefully you'll tune in for that. Keep an eye out on the website for that link. Naga, it'll be his second presentation, so we're really excited that he enjoyed it so much that he wants to present again. And if any of you guys are interested in presenting, you can send me an email. My email is up on the Connecticut PT website, ctpt.org. And you can just go online and register for any of the upcoming journal clubs that we have. And I hope you guys stay safe and healthy, and we'll see you guys next time.
You do the same. Thank you, Steph.
Bye,
Thank you,
everyone.
Naga. Thanks all.